Standardizing Nursing Management of Fecal Incontinence in Critical Care Patients, a Quality Care Improvement Project by myself, Rebecca Caprio. As all nurses know, pressure ulcers are a major concern. In order to begin implementing a change, I needed to pull together a multidisciplinary team in order to ensure we had unit-wide collaboration and compliance, as well as the necessary help and expertise from multiple nursing leaders and physicians. My team included the following: my unit manager, who is an RN BSN, and she helped identify the problem, develop the aim, as well as ensuring compliance and providing education. The critical care educator also aided in developing the aim, and she is in charge of educating the newly coming critical care nurses that are coming up and starting their training. So she'll train them fresh out of their orientation, as well as helping new or in-place nurses learn the process and what we're going to try to accomplish with this intervention. I included both day and night shift team leaders who are in charge of helping collect surveys, gather opinions, assess the need for changes in the intervention, as well as ensuring nursing compliance with updating their education regarding the intervention I've chosen to use. Lastly, I included a SCIM team nurse practitioner. They usually only round about once a month as needed, just for education purposes, but I wanted to make sure I included them because they know best how to treat incontinence-associated dermatitis, as well as how to prevent it, which could lead to the development of a pressure ulcer. So she was able to offer to come in twice a week and assess some skin, as well as update nurses and answer questions regarding the use of camelceptine. With my critical care nurse educator and the help from my unit manager, we developed an aim for the project based on last year's ICU pressure ulcer rates. After intervention implementation, our goal is to reduce the incidence of ICU acquired pressure ulcers to 6% or less within 12 months. Looking at the graph below, you can see a general timeline of the 4 months already achieved in the implementation process. Around the middle of February, education sheets were handed out to nurses to update them on the use of camelceptine, when to use camelceptine, when to not use camelceptine. You could see our rates drop to 7% by March. There was a disconnect there in March with some of the physicians in ordering of camelceptine, and it did go back up to about 8, but it is still less than our current last year's rate of 8.8%. I feel in 12 months that this will trend back down with overall compliance and the use of PSA cycles. My unit currently utilizes a Braden scale during charting to determine a patient's risk for developing a pressure ulcer. The Braden scale does not address fecal incontinence. It only considers moisture as a risk factor. Moisture can be considered present for many occasions, someone who is sweating, for DTs or someone whose catheter is leaking. It does not specifically address fecal incontinence. Fecal incontinence and circulatory compromise are the biggest influencing independent factors in the development of ICU hospital-acquired pressure ulcers. In one study, nearly half of ICU-acquired pressure ulcers developed on the sacrum, the hotspot for fecal incontinence. In order to effectively reduce the rates of ICU pressure ulcers, all risk factors must be considered and addressed. Every shift does complete every 4-hour gastrointestinal assessment. However, the bowel movement documentation screen does not include incontinence as a choice. The nurse must freely type in incontinence if she decides to do so, otherwise it is not documented. Physician notification must be made once there is more than one episode of fecal incontinence. Physicians should order protective barrier cream once they are notified. That way the patient this can be addressed next cleanup for that patient. The Omnicell will stock the ointment, and then nurses must have it in the room and scan it into their electronic medical administration record. That way we can ensure that nurses are being compliant and that the ointment is in the room in case needed for a next routine care. Here's a quick look at the Braden scale we use in our ICU. There is an error at the bottom. You could see at very high risk it says greater than 9. However, it should say less than 9. Nurses know this in our unit. Most of our ICU patients range from about a 14 to less than 9. So they are moderate risk or go all the way up to very high risk. We rarely have a patient who is a low risk. You can see under the moisture section that it does not specifically address fecal incontinence. However, you do have 4 choices of constantly to rarely moist. So there is some degree of consideration there. However, some nurses don't consider fecal incontinence as a moisture exposure. That could be a matter of education, where they went to school, what they were taught, as well as lack of protocol here in the unit, which is what I am addressing. In my first PDSA cycle, my pilot cycle, I did plan to test the ease of use and increasing intervention use was my goal. And the question I asked was, would MD order requirements reduce the rates of use? I figured that if nurses did not need a doctor's orders, that it was something they could get on their own, that they would be more likely to use it. So I did offer that. I did provide education regarding a silicone-based barrier cream that did not require a physician's orders. And then I did study what they were doing, and I also got survey results and asked them what they thought and if they thought it was working or not. I found that nurses were not using it as often as I had hoped. They were either busy or forgot about the intervention altogether or used their own method of prevention. So I did map the data at the bottom according to the results. You can see for the first week of this PDSA cycle that the number of incontinence patients is the dark blue. We did have a matchup on day 2, right after education, and some of the staff was present for those 2 days in a row, and they did use the silicone-based barrier cream. Then by day 3 and 4, there was a decline in the use of the ointment, and then you can see all the way by day 7, there was a total lack of use of the silicone-based ointment. Not one patient received it for that day. Then I had to develop a PDSA cycle 2. For my second phase of my PDSA, or my implementation phase, I did implementing the change I found was one of the hardest things, and I did determine that I was already showing improvement in my previous PDSA as well as in the short months, and I asked a similar question, and I said, do my doctor's orders of my implementation time frame was the innovation, so I had a multidisciplinary team that was using ideas who was going to help and educate physicians. I had changes spread to other units. Attending the organization that was potentially having the lowest PU rate residents being required to
change some of their education and revisit some of the things, and it's all online. And what was the patient's best interest. They were able to see emails and read them on the change on care accepting an appointment. They could sign
is different than the
move to the outdated information, and they were able to
of the hospital,
so they were able to see the handout as well as entire populations
and the units for implementation of adapting from the clinical educator that she sent out
because it's something we always calculate anyway. So
managers and messengers
to ensure that there's compliance and nurses been updated. Don't want their pressure, their patients to develop pressure.
Results of the ongoing intervention
notified nurses are always needed how to obtain education results from nurses, why they were there all night as well.
Evidence-based practice.
So there's always someone you can just use or to capture the narrative for your patient and nurses. The results are helping not barriers the larger number of nurses that pretty big unit. So we have to make sure that everyone's in a low number of patients in order to make the changes necessary. Because it's really not been implemented yet in the hospital on a bigger scale, which I plan to hospital life, there would be more accuracy cycles needed as each appointment is unique, as well as the residents change out on a daily basis. Prevalence rate will still be updated and know what's going on by March. Understand incident issues, a lot of vacation is the amount of common patients versus the number of patients being held the amount of patients and the frequency of time don't have the help and the PU incidence rate and receiving preventative treatment based on the numbers of patients. And if they do not have the making ready, quality nursing care, take extra time to put it on versus just actually the nurse quick and putting them back, you do have to